Okay, good afternoon, everyone. Welcome. Thank you so much for joining us. A second ago, I was telling people that are already logged in to please let us know where they're calling from. Please use the chat box to let us know where you're calling from, your name, and if you have any unanswered questions from the kickoff. It was great to see you all. The energy in the room was fantastic. I hope you all enjoyed it. So today we're going to focus on the data tools and processes for the project, for the initiative, what your hospital will need to collect and report to support the initiative. So let's get started. Just as housekeeping reminders, please mute yourself. We do want this session to be interactive. If you have any questions, please raise your hand. You can use the reactions option in Zoom to raise your hand, or if you want to send us any emojis. Or you can also use the chat box to put in your questions, and we will get them during the Q&A. This webinar is being recorded, so please keep that in mind, that this will be available for you afterwards if you would like to share with others, as well as the slides. I think you all know me by now, but my name is Estefania Rubio. I am the data manager for FPQC. I have Benjamin Gessner, the QI data analyst that works with us. He's fantastic. You will be hearing a lot from him today and in the next months. And I also have Dr. William Sappenfield, our FPQC director, and we appreciate your participation today. So just as a reminder of why we're doing this project, during kickoff, Dr. Sappenfield and our clinical leads made a fantastic job at sharing with you the reasons why we're focusing on SDOH. We know that the US has a huge maternal mortality crisis. We do have one of the worst rates of maternal deaths in the developed world, and Florida is not the exception, right? We do have a rate that is very comparable to the US rate. The thing that in Florida that has got our attention is the percent of women that die during the postpartum period after they have been discharged. So you can see that depending on the year, that can be half of the deaths or a third of the deaths. It's a really high percent of women. And we have noticed that those women die within the first 60 days after discharge, right? Talking about preventability, 2/3 of those are substantially or moderately preventable. So these women could have been, their death could have been prevented. And that is something that is really a call to action. What can we do to prevent those deaths? When we look at the data disaggregated by several factors, you can see that the majority of deaths occurred on women that were Medicaid recipients, that were obese, type 3, that had more than 35 years of age, and that were in the non-Hispanic Black group. So we know that there is a huge health disparity. We know that some groups are disproportionately affected. And so the big question is, what can we do to prevent those deaths? What can we do to prevent those high morbidity rates and those huge health disparity gaps that we see when we look at our outcomes? And so a huge paper put out something that is really shocking, right? Only 20% of the health of a person is related to healthcare, and that is access to care and quality of care. Only 20%. Everything else is related to socioeconomic factors, physical environment, and health behaviors. So when we think about social determinants of health, it's a more integral way of taking care of our patients, thinking about all the other things that could be affecting their health and giving them access to additional resources. So if they are in very difficult situations, they can have a better outcome. And, there's many national institutions that have identified this need for SDOH screening and referral. I'm just adding here the ACO committee opinion that came out on 2018 about the need to screen our mothers for SDOH and then to maximize referrals to social services. In line with that, we have developed with a whole realm of advisors the SDOH initiative. And just to have in front of us, our aim for the initiative is that by 2024, our SDOH hospitals will do two things. We'll achieve a 20% increase from baseline in the percent of patients with a positive SDOH screen who are referred to appropriate services, right? So heavily on SDOH screening and referral. And then the other one is that at least 80% of their providers and nurses will attend a respectful maternity care training, and we're only going to count trainings completed since January 2023. We know that respectful maternity care is going to help us increase or maximize the referrals for SDOH. And so those two are different but complementary, right? We don't have baseline data for the project, so we are going to use the first quarter of the data that you submit to us as the baseline. And from there, we will, calculate how much of an increase you need to make from the baseline to achieve your goal. Once we agreed on the aim, we identified 4 key drivers. So data insights, respectful maternity care, universal SDOH screening and linkage to services, and family and community engagement in QI work. These 4 drivers are different, but they work simultaneously to improve SDOH and respectful maternity care, right? And so in the next hour, we're going to review the measures that we are going to be collecting to inform each one of those drivers. And so with that, we're going to have 3 types of data. We're going to have patient-level data, hospital-level data, and their respectful maternity care survey, right? In the patient-level data, that's going to focus heavily on SDOH screening and referral. The hospital-level data is going to focus on the staff education, respectful maternity care, and the policies and guidelines to support SDOH. And in the respectful maternity care survey, we're going to ask you to distribute a survey to your patients so your patients can tell you how they felt during the admission for delivery, if they were recipients of shared decision-making, and if they perceive their care as being given with dignity and respect. And so let's focus on the first one, right? Let's start with that one, the patient-level data. We're going to ask you to report that monthly. As I told you before, this one focuses heavily in SDOH screening and referral. And there's going to be 2 types. You're going to submit data as an aggregate for all your patients, and then you're also going to submit a sample of just 10 mothers. That is going to be more granular. It's going to ask you more about those specific mothers. So for the patient-level data, the aggregate, right? These are the questions we're going to be asking you for all your patients that were admitted for delivery and discharged home. So these, you're just going to tell us a number, right? The first one is the number of patients discharged home after delivery. We all know how many mothers delivered at our units. So that one is a number that you will have to provide. For the number of patients discharged home after delivery with SDOH screening documented with an SDOH screening tool, we're giving you 2 options, to give us the number or to tell us unknown. We are hoping that you only utilize unknown the first couple of months, because SDOH screening is something that we need to implement for the project, but we understand that at the beginning, you may not be able to capture that in the electronic medical record, and it may be difficult to tally for all your women. So this unknown box is something that is available for you, but we expect that you will just use it in the first couple months. So the third one is related to the number of patients that screen positive for SDOH. And then the fourth one is those women that screen positive for SDOH and were linked to services, right? So you have total deliveries, women that were screened, women that screen positive, and women that are screen positive and were referred to appropriate services. And you're just giving us the total number for all the women that were admitted to your unit and discharged home. Now for the second section, you are going to report more granular data only on 10 women. And here are the inclusion and exclusion criteria, right? You're going to abstract for the first 10 women admitted for delivery who screened positive for SDOH and were discharged home. And you're going to exclude women with a fetal or infant demise. So for those women, you're going to provide additional information. We're going to ask you demographics. So you're going to provide when the discharge occurred. And we're just asking you the month and year. We're not asking you the day. And so this was very purposeful. When you are doing your data user agreement, sometimes they will ask you if there is any patient health information that we are collecting. And if we do the complete date, sometimes that may cause issues. But please remember this, we are not collecting any PHIs, and the date that we are collecting is not complete. It only has month and year. So that shouldn't be a problem. We're also asking you if the discharge occurred during a Saturday or a Sunday or a holiday, right? We know that referrals can be impacted by when the discharge occurs. So we want to know for these women when the discharge occurred. We're asking you how many days the women stayed in your unit. So length of stay in days, their race, their ethnicity, their preferred language. Please remember all these options should be self-reported. The patient should be able to complete that information herself. And for the age, we're asking you just complete years. For the type of insurance, you can tell us if it was Medicaid, private, self-pay, other, or unknown, and the entry to prenatal care. So was it in the first or second trimester, the third trimester, if there was no prenatal care, or if it was unknown. The reason we collect demographics is because this informs case composition and it allows us to track population change over time. In several projects in the past, we have seen that this doesn't change over time. And that's good because when we compare the measures, we want to make sure that the population type remains the same for the entirety of the project. So this is just going to inform that. It also allows us to disaggregate the measures to identify differences between populations. You know, we talked about how we can address health disparities. The first thing we need to know is if some populations are disproportionately affected, right? And for that, we need to disaggregate our data. So these will let us disaggregate our data and let you know which groups have the biggest needs. For length of stay, we have agreed on this definition. You are going to count the days if the patient was in bed at midnight, right? And for the age, we're asking you that only you provide complete years and to never round up. So if the mother is 33 and her birthday is in 2 days, but she's going home today, she is 33. We're just providing complete years, and that's about it. Okay, so for the second section of the information you're going to provide for these 10 women is the information on SDOH screening and your action plan for the screening. So these are the 5 categories that CMS, Joint Commission, and many hospitals already collect. They are food insecurity, housing instability, utility needs, transportation needs, and feeling unsafe at home or having intimate partner violence. We're giving you an option to tell us if you are collecting any other SDOH screening in case the mother was positive for those additional SDOH. So here you can check which one the mother was positive for. And for each one of them, we ask you that you tell us what was the action plan for that positive screen. So was there a further assessment completed, usually done by the social worker, the case manager, the patient navigator, to assess the total extent of the adverse SDOH and to schedule or refer to resources where available. We ask you if the patient care of plan was adapted because of that positive screen, so you will tell us here, and if the referral was arranged prior to discharge. So here, all of these are check all that apply, right? So you will tell us all the screenings that came back positive and all the action plans that occurred for each one of those categories that the mother was positive for. Now, many of you are probably not collecting all that information in your EHR right now. This is a huge ask. We ask that you start working with your IT team, or if you need to use a paper form in the next month, that is what your team needs to figure out. Do we collect this in the EHR? Where is it collected? Are we using it? Is it standardized? Is everybody documented in the same place? Do we need to use a paper form? So those are questions that your team will need to discuss and put something in place so you can start collecting this information starting in July. So all that we discussed right now, social determinants of health, screening, and linkage. Just a reminder, that's one of our aims, and that's also one of our drivers. We do want to have universal screening, so all your mothers should be screened during the delivery admission and referred to services where needed. And, we understand this is an ask for the initiative, but CMS will require reporting starting in January 2024. So we are just giving it a jump start, right? So when January comes, you have all this information already in the system and you are able to easily report. So think about it as, yes, we're going to have to work on this, but it will be both for the initiative, for our patients, more importantly, but also because it will help you with your CMS reporting. If you're a Joint Commission hospital, it will also help you with Joint Commission accreditation. The screening tool that we discussed in kickoff was the Prepare. This is a nationally standardized patient risk screening for social determinants of health. It's available in 25 languages. So if you don't have something in your EHR and you need to use a paper form, or you need to access a form in a different language for patients that are non-English speaking, this is an excellent resource. You can find it in our toolbox, or if you don't need it, just shoot us an email. We're happy to email it to you. For linkage to services and resources, we discussed Healthy Start. FPQC is partnered with Healthy Start to create a community resource directory. So you need to connect with your Healthy Start coalition member if you didn't do at kickoff, and start working on the community resource directory. They will help you. They know the best resources in your area. And so they will provide to you a community resource directory for the initiative that you can take advantage of. There's also other organizations available. We discussed at kickoff, Unite Us, Find Help. So if you have those at your facility for your community, those are fantastic resources as well. The important thing here for data collection, at least, which is what we are discussing today, is that you standardize documentation, right? So this is how the data collection form looks like for the patient level data. You're going to have your aggregate data at the beginning, right? And then for the granular 10 patients, you're going to have this box for each one of your patients. In the back, this is just the same information for additional patients. So you can have 1, 2, 3 patients here. You're going to have to print the second page many, many times so you can complete the 10 patients, right? The form is fillable. So, if you like to keep your records electronic, you don't need to print. If you like to print, please go ahead and print the PDF. This is just an option for those that like to have it virtually. And the data form is exactly in the same order that the data portal. So remember, you're going to abstract all your data in your data form, in the form that you're looking at right here. But for submission, you need to send it to the FPQC data portal, which is what I'm going to show you next. An important section of the form, if you look at it here, it says a study ID, right? Study ID. If you worked with us before, you know that that is just a number that you are going to assign to each one of your patients. So you're going to start with 001, and then you're going to number sequentially until the end of the initiative for each one of your cases. So in the first month, you're going to go from 1 to 10, second month, 11 through 20, and so forth, right? Please do not restart numbering every month. That is something that sometimes occurs, and we need to fix it. So from the start at 001, and then continue numbering sequentially until the end of the initiative. We ask that you please keep track of your cases. So every single case that you send to us, please keep the medical record number next to the study ID that you assign to that case, and the survey return code, and the person that completed that information. We give you this log. You can keep it as we provide it, but if you have another log that you prefer to use, go ahead and use it, but we highly recommend that you keep at least these 3 columns, right? The medical record, the study ID, and the survey return code. If there is any issues with any of your cases, we're going to only be able to provide you with the study ID. So you need to be able to connect back to the medical record if we need to change or correct anything. And this is also a very good practice, so everything gets organized in case you need to hand it off to somebody else. So please remember to keep this log. Never ever send this log to us. We don't have permission to see the medical record of your patients. So please remember, this is only for in-house, for you to use with your team. Never send this to FPQC. So for the process to submit your data, right? You identified your 10 cases, you abstracted the medical record of those 10 patients. Now you have those forms completed. The next step is going to be to submit your data into the REDCap portal, right? Once your hospital completes your data user agreement, once it's fully executed, we will send you the links to your data portals. And in the data portal, you're just going to input all that information. So I did want to give you just a sample of how it's going to look. This is just my email. This is how the email that comes to you looks like. You're going to get your instructions, your forms, and then the dates and the links. So when you're going to collect patient level data, you're going to start in July. You're going to submit by August 15. And here's the link. This is a fake link. I just wanted to show you how it's going to look for you. The actual link we'll share with you once data user agreement is complete. But basically, this is what the data portal looks like. You saw that I just clicked. This came up for me. You're going to input your hospital name. For now, this is just an example. So we're going to say that we're sample B. Here, I'm going to ask you to be very careful of the name that you select. There's a lot of hospitals that have joined us from the same network. So, you know, we have a lot of Advent Health, we had a lot of Baker, a lot of Baptist. So it's very, very important that you select the correct name for your hospital. Otherwise, it's going to get inputted in the incorrect place, right? And we usually, either Ben or myself will reach out to you if we see any issues. But that is one important step. And then you're going to give us the month of discharge. Let's say that this is going to be April 2024. And then, you know, we talked about the aggregate numbers. So you're just going to give us the number of women that were discharged home during that month. You're going to tell us how many of them were screened positive. Were screened for SDOH, how many of them screened positive, and how many of them were referred to appropriate services, right? If you don't know any of those numbers, we gave you the option to use unknown. But again, those unknowns should only be used the first couple months of the year, of the initiative, because over time you need to start implementing those changes in your EHR so you can tally documentation of referrals and screening. And then you're going to start providing the data abstracted for your patients, right? And this is going to be for your first 10 women that is screened positive for SDOH. So the study ID, we're going to do 001. We're going to say this woman was discharged on a Friday. The length of stay was 3 days. She was Black, non-Hispanic, English-speaking woman, age 25. She had private insurance. She had early prenatal care entry. She screened positive for transportation needs. And let's say that in the further assessment was completed by social services, and she was putting transportation resources from her insurance, right? Here, I'm gonna put my email because I completed this form. And now I'm gonna go to the next patient, right? So for the next patient, you're gonna say 002, and you're gonna complete the whole form, right? Once you're done with the second patient, you have another patient, yes, because you have to give us 10. So you go through the same process 10 times, all right? And once you're done, you're going to say, okay, do you have more patients? I'm gonna say no, right? And once I say no, I submit. Once I submit, I'm gonna get this return code. So the return code is what I'm going to use if I need to go back to that form and make corrections. So when I was telling you about keeping a log, remember, I asked you to please keep that survey return code in your log so you can refer back to your cases. Because of the way that we set up the survey this time, you're going to have the same code for the first 10 patients, right? And then one code for every 10 patients you submit to us. But it's important that you keep track of the medical record for each study ID. Okay, that's it. Questions until now. I'm going to stop sharing for a second. And do you have any questions so far? Is there anything that is not clear that you'd like to get clarification on? Anything at all?
So this is, hello,
Yeah, hey, Anne, I can hear you. Go ahead.
it's reverberating here. I was just wondering, the questionnaire, do you have one that's individual in the portal so that you can just copy it and hand it to the patient? Or does all of them have all three entries on it?
I apologize, there is some interference. I couldn't understand your question. Ben, did you get it? Maybe it's just on my end.
I'm sorry, I was unable to hear it. My apologies.
Could you please tell us your question again? I apologize. There is just some strange noise that's a little difficult to understand what you're saying.
I just had a question about the screening tool.
Mm-hmm.
And is there a screening tool in the portal that's individual per patient, not the one that has multiple patients on it? Is there a tool that you can just copy and use as your survey?
Okay, so the screening tool that you utilize is going to be up to your hospital. Prepare is just one of the options that we give you. And some places already have SDOH screening in their EHR system. So you can use whichever your system is already has in place. And if you don't have one, you can use Prepare or you can use others, right? For the data submission, we're just asking you that if the patient was positive for any of the SDOH screening categories, that you report to us.
Okay, so where do we get this Prepare?
The Prepare, I can give you the link. We can drop it in the chat in a second.
Okay.
Yeah, no worries.
And Estefania, we have some in the chat as well.
Mm-hmm. Okay.
All right.
So is the email address collected that of the person collecting, certifying the information, or the one who transcribed typed into the portal? So the person that transcribed and put it into the portal, please. It's just the patient that is submitting the data that needs to put their email in there. I highly recommend that if there is two people, one for abstraction and one for submitting the data, that you keep track of that, especially if it changes over time, so that you can, know who abstracted and who submitted. But we want to know who submitted, because when we go back, we will be able to tell you this person submitted, and you will make more sense of who needs to correct it or why the issue happened. And then says, is there a standard script or further definition that helps define insecurity and or needs? So in the Prepare screening, there is some definitions in the back, but when we were looking at the literature, the recommendation was that you use standardized forms. So yes, there is some definitions that are available to you. Gravity Project provided some very good definitions. You can select the definition that best fits your community and your needs, but yes, there is a standardized definitions for those. And we can provide that to you as well. Okay, clarification needed. These 10 patients are those who were positive for at least one SDOH, correct? Yes, that is correct. You're going to give us 10 that is screened positive for SDOH, and it can be one or more. Okay.
And then we had 3 up there. Alexis, yes, these slides and the recording should be available after the meeting. As to the exact date of when the recording will be available, I'm unsure, but I believe in the coming weeks.
It should be, I'm sorry, this is Nicole from FPQC. I think the recording should be ready by tomorrow. Check back at our site at I'll put it in the chat. but it should be up there by tomorrow. Thanks.
Thank you, Nicole.
And Juleka asked, if we don't have 10 patients with positive SDOH screen, what do we submit? You submit as many as you have, not a problem. If you had less than 10, you give us as many as you have. Okay, did I miss any questions, Ben? I think we covered.
Lance had asked, are we screening all patients, but only completing the granular collection for the first 10? So I believe.
Yes, Lance is right. We are screening all the patients, but we are only submitting for the first 10 that is screened positive. Only for the first 10 that is screened positive for SDOH. Okay. Perfect. I think those are all the questions. Okay, let's go back. Ben, go ahead.
All right. Can everybody see my screen?
Yep.
Okay. All right. My name is Ben, and this afternoon I'll be taking us through our hospital level data. For the purpose of this initiative, our hospital level data can be separated into both structural measures and process measures. The process measures for this initiative will be our staff education and training, and our structural measures will be the policies and guidelines that support the social determinants of health. Why are we collecting this? Well, these help us assess where your facility is on implementation, and this can help build your hospital and staff capacity so that you can successfully implement the SDOH initiative. All right, structural measures. Our structural measures are built out of our key driver diagram. In our key driver diagram, our primary drivers are data insights, respectful maternity care, universal SDOH screening and linkages to service and resources, family and community engagement and QI work. All right, so for our key driver data insights, our structural measures are as follows: developing process maps of key personnel, activities, and steps, taking information systems and timing to collect, correct, and document demographic intake questions, implementing a process to collect, document, and correct patient self-reported race, ethnicity, primary language, other patient characteristics, and SDOH, implementing a strategy to provide information to patients who have questions on why race, ethnicity, language, and SDOH are being collected. So a script, brochure, video, etc., anything that you can use to provide information to your patients on why they are self-reporting that data. And implementing a hospital's written action plan to address at least one identified health disparity. All right, so this is our process map as we saw at the kickoff, and this was just brought to us by our colleagues at the FPQC. This would be a process map going from when you are asking your patient about their self-reported race, any issues that you might run into, steps in between, and going all the way down to staff documenting the patient's self-reported data into the EMR. You can take this, it is a tool for you to use. You can completely change it, but this would just be an outline of a process map that could be used to help you implement that structural measure. In the structural measure that has you identify one key health disparity and create a written action plan, this is our SDOH dashboard and our PQI report. We will be having the PQI webinar later in the month, but in this dashboard, you can quickly identify a disparity that you may have and create a written action plan. If we look over here at the percentage of severe maternal mortality without blood transfusions, the hospital discharge record, we see that non-Hispanic Blacks have a ratio of 1.86 to the referent 1.0. We see that that may be a health disparity. That could be an area where your hospital could look into it and then create a written action plan to create change there. All right, so our second primary key driver that we go into is respectful maternity care. Our structural measures here are creating a strategy for sharing expected respectful care practices with delivery staff and patients, including appropriately engaging support partners and/or doulas, and implementing the respectful maternity care survey to obtain feedback from postpartum patients on respectful care practices, and a process to review and share results. So here, this is our RMC commitment handout. These provide actionable strategies that you can impact your patient care. You can use this version in your hospital. If you want to change it in any way, edit it and make it your own. If you don't like any of these strategies, you are completely able to do that. Please use this document as an outline for yourself if you need to change anything. But this is just a good example for you, and it is also available to all teams. This can serve as a standard part of your new team member onboarding, and it will be included in FPQC RMC regional trainings. The third driver of our structural measures would be universal SDOH screening and linkages to service and resources. In this, our structural measures are implementing a process, protocol, or guideline for screening patients for SDOH during delivery admission, and implementing a protocol, process, or guideline for referring patients to available community resources and services. So you see here, in this, our structural measures are having a process to both screen patients for SDOH during delivery admission, and if they screen positive, having a process to refer them to the available and needed community resources and services. And the last driver for our structural measures would be family and community engagement in QI work. This is implementing a strategy to educate your QI team and leadership about family and community advisor involvement, engaging a family advisor to provide ongoing input, and engaging a community advisor to provide ongoing input. We heard in our kickoff, in our presentations, how important it is to have a family community advisor. And this is just having a structural measure so you can track where you are on getting a family and community advisor into your hospital. Okay, our process measures. This would be staff education and training. This is where you report your cumulative percent of having your staff received education on processes for developing an agreed upon plan of care utilizing a shared decision-making model. In this, you report a cumulative percentage of nurses and a cumulative percentage of OB providers. Also, having to report that cumulative percent for having your staff attended a respectful maternity care training since January 2023 and committed to respectful care practices. This is one of our aims, where we want to have at least 80% of providers and nurses having attended an RMC training since January 2023. So you'll be able to quickly see in your dashboard how you are doing in regard to that aim as we go through the initiative. And some available trainings with your respectful maternity care components. So ACOG has the respectful care e-modules. A1 has the respectful care implementation toolkit. ICM has respectful care workshops. Perinatal Quality Institute has the Speak Up. March of Dimes has awareness to action. And as well, FPQC is also planning to offer 4 regional RMC trainings, and more information on this will be coming in the next few months. Okay, so you saw your patient level data collection form. This would be your hospital level data collection form. And if you were involved in PAC, you may be familiar with the formatting of this. At the top, we have all of our structural measures, which are measured on a Likert scale. We see here that they start on not started and go all the way up to fully implemented. Fully implemented would be if you've implemented the structural measure for at least 3 months with 80% compliance or more. Implemented would be if you've implemented for at least 3 months with less than 80% compliance. Started to implement would be when you first begin to implement that structural measure within the first 3-month period. Planning would be if you're putting in the infrastructure that you need to implement, but you have yet to start implementing. And not started would be that you're not planning to implement yet and you're not quite there. Down at the bottom, we see that we have our staff education and training, as previously talked about on the previous slide. We see that you just have your cumulative percentages that you input here. And this as well will be available in PDF so that you can go through, you could print it out if you want and write it freehand. You can also go through, it is available in a checkbox format where you can use a PDF and go through and just list all of these structural measures out to see where you are. So the process to collect and submit your data. So once you're done with your hospital level data collection sheet and you have reported an update of all your structural measures and you've tapped the REDCap data portal, I know we previously just went into how to do this with going through this with the hospital level, but your links will be sent to you for the project once you're. And with that, I will be handing it back to Stephanie. Stephanie, are you there?
Yes.
Ben, you
Thank you,
seem to
Ben.
be freezing up, Ben. The sound was going in and out, just so you know.
Just a bit. Thank you, Marty. Yeah. I know
Sorry
it's
about that.
No worries. You did great. So As Ben was showing you, for every structural and process measure that we have in the initiative, there are tools that our team and our advisors have compiled from national organizations and are available to you in the toolbox in the FPQC website. So please make sure to go into our toolbox and to our toolkit, and you will find those tools. If you ever find yourself not knowing how to implement something, we will have those monthly coaching calls where we can have those discussions, or you can always email us if you have any questions. But there are tools for every single one of those measures, so please don't feel like you have to reinvent the wheel. Okay, so the last section is the Respectful Maternity Care Survey, which is going to be patient self-reported, right? And so here we're going to ask you to implement a survey. Let me see. Okay, there you go. So we talked about it at kickoff. Remember, the team was able to adapt a survey. It's going to be available in 3 languages: English, Spanish, and Haitian Creole. We had family advisors take the survey and tell us that it was a proper survey. They tested it. They gave us really great feedback, and it collects their perception of the care they received during the delivery admission. So the patients will, when you implement the survey, we will ask you to share with your patients a QR code. And, everybody now has phones that can scan the QR code, but we do ask you that for the few people that may have issues scanning the QR code, or, for some reason can't scan the QR code, that you provide a device so the patient can take the survey. So in regards to the survey, the big task for you will be to make sure that you can distribute the survey to the patients. So if you need to get permission from your administration, that's a process that you need to get started now, so you are able to implement as soon as possible, and that you have a device available for your patients to take the survey if they don't have a phone. Other than that, FPQC will provide to you the information packet that will include the script that you see there on the left of the survey, telling patients that it is voluntary, that it's just an opportunity for them to share their experiences with your team. Their answers will remain anonymous, and the survey itself doesn't take long. At most, it will be 10 minutes. So, we do have that script available for the patients, but if, the best practices come from actually a nurse or a physician telling the patient about the survey and sharing why having that information is important to the team. We want to use your voices, patient voices, to improve the care we provide. And so it's important that that be shared adequately so patients are more likely to take the survey, right? And we did it on the languages that are more common in Florida. So we want to increase participation by also providing it in the preferred language for the patient. Once your data user agreement is complete, each of your each hospital will receive a hospital-specific QR code. So please do not share with other hospitals, because that will muddle your data. Once we send you the QR code, that is yours to keep. Many places laminated that QR code so they could, easily share with patients. Some people put it in the bedside, so it's something that patients can quickly access whenever they have some time and they want to do it. We recommend that it's done closer to the discharge, so they have a whole experience of the admission. But yeah, those things will help. And again, giving patients privacy to do it is important, but sometimes if you help them get the survey started, you will have better results with completion. So this is just a sample of a section of the survey. We are going to ask the patients to, in a Likert scale, tell us how much they agree or disagree with the several statements listed on the left. So here you can see that the statement says, I could take part of my decisions about my care. I could ask questions about my care. My healthcare choices were respected by the healthcare team. So it talks a lot about dignity and respect and shared decision-making. It's a great survey. Okay, so we have gone through a lot, and I'm giving you this very heavy key driver diagram, but we pieced it out. So now you have reviewed by sections every single section of the key driver diagram. My ask to you is that you keep this key driver diagram as a way to plan and direct your team to the things that you need to do and the things that need to get done. So please use this as a planning tool to help your team steer in the right direction of where you need to go. Okay, Ben.
All right. Can everybody see my screen now?
Yeah.
All right, I'm going to keep my video off to try to make the most of my Wi-Fi. All right, so today I will be taking us through a few sample graphs that will be included in your monthly QI report. So the first one is just a run chart, also known as a trend line. We see here, this takes your percentages and it moves a line over time. You see in January of 2020, we were at 0%, and we see how the line moves over time based on your percentage. This is very, very helpful if you want to track how you're doing with a specific measure over time. So we see here, this would be for the percentage of patients for whom screen for SDOH was documented in EHR. So if you wanted to track this over time, it would be easy just to go in and look at a snapshot of this run chart to see how you've been doing. All right, so this, very similarly to the last chart, would be a run chart as well. But what is different about it is that we have a box plot in the background. So this would be a hospital comparison trend line where you can see how your hospital is doing compared to the other hospitals in the initiative. You'll never be able to see any other hospital specifically, but this would be your overall initiative statistics where we see in different quartiles what trend line you may be laying in. So in the green portion at the top, that would be the highest 25% of hospitals. So, from 76% all the way up to 100%. In your second one that is blue, that would be the highest 50% of hospitals. The purple would be the lowest 50% of hospitals, and the red would be the lowest 25% of hospitals. As we look at this line with the black line, which would be a run chart, we see that we follow the median line. So that would be right around the highest 50% of hospitals. And that is represented with a pink dashed line. So you can see when you go and look at your hospital comparison, how you're doing in comparison to all of your surrounding facilities. All right, so if you are familiar with the PAC initiative, if you took part in that, you may recognize this screen. This will be our hospital level measures, and this is how we'll be displaying them. On our left, we have our legend, which shows our structural measures. Green with a check mark would be fully implemented. Green would be implemented. Yellow would be started implementing. Red, planning. And red with a cross would be not started. So you're easily able to go in and take a mental snapshot of how you're doing with different structural measures and seeing, all right, implemented strategy to educate patients on the importance of self-reported patient characteristics. We are fully implemented with that, and you're just easily able to go in and look at how you're doing. On the right, we have our process measures where we are able to see how you're doing with your staff education and training. So for educational criteria, if you were looking at the process for developing shared decision-making model, you look and you see that you have 50% of physicians and midwives educated and 40% of nurses educated on this. If you want to see your RMC, your Respectful Maternity Care Training Seminar, which is one of our aims, you're able to go in and look and see if you've reached that 80% mark as well. And over time, you probably will start with a low percentage, and that's all right because that's baseline data. But towards the end of the initiative, we want to see that you've reached a higher percentage and that you've improved over time. So how do you use your data for improvement? So initial data points will be a surrogate baseline. As I was saying at the very beginning of the initiative, we expect very low rates, and that's regular of any QI initiative, especially when you're implementing all of these different training packages and structural measures and so forth. But you review your data every month and you evaluate to guide improvement. So if you look at your run chart on that first slide where you see that you may be at a low percentage, you say, we may want to improve this. So you may put in a PDSA cycle to improve that over time and see how that has affected that measure over the next few months. And you use that to prompt discussion and action. As well, you create a system that can be maintained long after the project ends and check if you are holding your gains over time. So a lot of the time when we start an initiative, we'll see significant improvement in the beginning while it's a hot topic and everybody's, moving forward and wanting to improve in this. But over time, enthusiasm will fall a little. But your data that you report will maintain. So one thing that you want to do is just make sure if you do see any of your trend lines beginning to drop, that you do whatever you can to maintain those being higher than lower. You want to see improvement and not decline. And then the last piece here would be that data is for learning and not for judgment. I know we offer that one trend line that has the box plot in the background, this one. We don't want to make that something where you feel, bad about where the rate might be, but we want to use that to, help you see where you're doing in areas that you can improve in. Rates can be deceiving. There might be a measure where you might have a 20% for that one measure, and you might think, well, that's bad. But when you look at the box plot, you may see, relatively, you might be in the highest 25 percentile for that measure. So we just want to make sure that you learn from all of this data. And not just to make sure that you understand it's not for judgment in any form, but all for improvement. All right, so your monthly cycle, okay? So we'll start with submitting data because this is the data webinar. So let's say in your monthly cycle, you start by submitting your data to us. And then we send you your report. So your report will have your aim, your run charts, it tracks your process and structural and outcome measures. And as well, we're going to add your PDSAs. You take this data report and you discuss and disseminate the data report in your hospital. If that's putting it up on the wall, discussing it at one of your meetings, something of that sort. And then once you figure out an area that you can improve in, you identify that opportunity and you might run a PDSA cycle. Once you have run that PDSA cycle, we have our monthly coaching call meetings where our great nurse and physician coaches will go over these PDSAs with you and talk about any strengths that you had, weaknesses, barriers, and talk to other hospitals in your team to see ways that you can improve and ways that they have improved as well. And with that, I will be passing it back to Estefania. Thank you all so much.
Stephanie, if you're speaking, I can't hear you.
Hey, thank you, Margie. That was a hiccup there. Thank you. So Ben, thank you. That cycle is great because it helps you remind your team of the planning that needs to take place for the next months that you will be participating in the initiative. So that cycle will repeat monthly. So please plan accordingly with your team. Now, for important requests, we ask that you please track the completion of your hospital data user agreement. We are not able to share any links with you for data submission until that is complete. So that is a very, very important first step. If there is any changes in your SDOH team, please let us know. We want to make sure that we are contacting the right person. The links and the resources for the data will go to the data lead and the project lead. So we need to know the right person. And the next thing that you need to plan for is your hospital kickoff in July. So data collection will start in July. And with that, your screening, your SDOH screening, and your survey implementation. So please make sure that you plan with your team on activities that you can do to engage your providers, to engage your staff, and make sure that you plan accordingly for data collection and survey implementation. For dates, so we are going to ask you to complete your hospital level data by June 21st of this year, right? So that's going to be next month. And then every 3 months thereafter, right? So the cycle is going to be in September, in December, in March, and June. So that is your structural measures and your education for your staff. That's going to be just every 3 months. And the first time that you're going to give us data on that is going to be June 21st. We understand that many of these things are not implemented yet. So if all of them are going to be not started yet, don't worry about it. This is just the beginning of the project. We don't expect you to have everything in place by that date. This is just going to be our baseline, right? So first, that's going to be the first deadline. The second deadline is related on patient level data collection. That is going to start in July. And you are going to submit your patients for July on August. And the deadline is on August 15th. For your monthly data, the 15th is always going to be your deadline. So for the month prior, you're going to submit your data on the 15th of the following month. The first time that you're going to submit patient level data to us, August 15th. The next thing is to attend the PQI webinar on May 31st at noon. So some of you have already registered, but most of you haven't. I did that on purpose. I didn't want you to confuse those dates. So you are going to receive the link to register today. Please do so and attend the webinar. In the PQI webinar, we are going to review the health disparities dashboard that we have been discussing, and it's going to help you identify those health disparities that you can work on and build that written action plan that is both a requirement for the initiative. It's also a joint commission measure. And you know, it's a fantastic opportunity for your facility to address the health disparity. Coaching calls will start in July and calendar invites are coming soon. So please look out for those invites soon. This is just, you know, a reminder of the PQI webinar on May 31st at noon. And with that, I'm going to open the forum for more questions or comments, suggestions, anything that we're missing. So again, you can put your questions in the chat box, raise your hand. Either one.
Alexis has her hand raised.
Alexis, go ahead.
Hi, yes, thank you. I have just two questions. Can you guys elaborate a little bit more on coaching calls? How does that process kind of work?
Margie, would you like to take the question?
Oh, yes. Coaching calls. We assign hospitals by groups to be together on coaching calls. Average size is about 10 hospitals. We like to keep hospital systems together. And you will have a nurse and a provider on your coaching calls, and I'll be on those calls as a nurse as well. And we send them out in advance, so you can just book them out a whole 6 months ahead of time. We're going to determine which day of the week works best for your nurse coach and your provider coach. And then we will send those out so you can get those on your calendars. Now, FPQC does send out these to you also when those meetings will be. And they also send out the reminder the day of, like at 7 a.m. or the day before. So it's really good. We're having great participation because FPQC does a great job getting it on your calendar and then sending you a reminder. So
Okay.
More to come on which coaching group you will be in.
Okay, so it's kind of like a Zoom situation, and is
Yes.
it confidential?
Yes, it is.
Besides
We do
just with
not
the 10.
record coaching calls. We do not record coaching calls. People share what people would like to share. We never share data. Unless we share data as aggregate, as Stephanie and Ben will explain further because of our data use agreements. Sometimes people will want to share how they're doing, which we can't, of course, stop that. But we do not, share any confidential information. So it's all up to really sharing and learning from each other.
Okay, thanks for explaining. And then my last question goes back to the hospital level data. So I know that we're supposed to report every 3 months. Now, are there like deadlines for hospital involvement, like for progression with answering those questions like implementation and yada, yada, yada?
There aren't deadlines for progression at all, but there just is deadlines for submitting an updated hospital report. We obviously want to improve over time. Stephania, you want to weigh in? Or?
Perfect. Alexis, that's a great question. We don't provide like deadlines for each one of the measures because we understand the situation for each hospital is going to be different. Things that are implemented at your facility may not be in others. And so that's something that you will have to plan with your team. But as Ben said, at the beginning, we're going to see a lot of red X's or, planning stages. Over time, we want to see those green check marks that you have everything implemented. But no, we don't have general deadlines for each one of the processes.
Okay, perfect. Thank you.
No worries at all. I see some questions in the chat box. So one of them was, do all patients do the QR code or only positive screens? So for the survey, you should offer the survey to all your patients, except those that have had a fetal demise or an infant death. We want to be very sensitive with that population. It may not be the first time to ask them about their perception of care, right? So those can be excluded, but the survey should be, offered to all the patients in your delivery unit. There is another question. It says the patient survey is voluntary for the patients and not voluntary for the participating hospitals, correct? So correct. We want you to please do the best effort you can to implement the survey. We understand that sometimes you will get a lot of pushback from administration. And if you do, please let us know. We have great clinical leads that could help you make a case for the survey. Sometimes, you know, I know there's other surveys the hospital is focusing on. We have done the survey quite different from surveys that are already distributed at hospitals. So they're not the same. They shouldn't be perceived as the same. But again, if you feel and if you get a lot of pushback from your administration for survey implementation, let us know. We'd love to help where possible.
Do we collect data for all patients? So every patient we would like to have screened for SDOH, but the only patients that you're abstracting for would be the first 10 positive for SDOH screened patients.
Yes, and remember that's a CMS requirement. We need to screen SDOH for all patients during delivery admission. And so that's something that, yeah, we do ask for all the patients, but then as Ben said, abstraction just for the first 10. Is there a sample of the questions needed in our EMR for the survey? So let me see, that was Yanemari. Yanemari, are you referring to the respectful maternity care survey for patients? Is that your question related to? And Yanemari may not be in the call anymore, but if the question was related to the respectful maternity survey, that's not something that you need to put in your EHR. The survey is built in Qualtrics behind the USF firewall. So you don't need to build the survey anywhere. You just need to share the QR code with your patients, and we will handle the data analysis, the collection, and the safeguards of the data set. We will share the report of the surveys with your team once we have 5 surveys, but that's not something that you need to build in your EHR. That's something that we manage.
When looking at discharges, is it only mom-baby discharges, or would an antepartum patient be included as well? Stephanie,
So no, right. Our inclusion criteria is only for moms that come for delivery and are discharged home, so no antepartum. Or if you have patients just being observed, patients that come just to the ER, pregnant, into the ER, we are not collecting information on them, just on women that come for their delivery and are discharged home. All right, any other questions? Anybody else has any pending questions? Alexis, go ahead.
Thanks. When you mentioned the CMS requirement, just wondering, will this initiative serve as kind of a one-stop shop if we're required to report this for CMS in January? Like, would your data serve as our submission?
So there is a couple of exclusions in the CMS that we're not asking, like they are asking for women over 18 years old. But the thing is that if you build the system to make the submission to us, it would be easier for you once you have to report to CMS.
Okay.
Right? We're building the hospital capacity and having it in the EHR, so when submission for CMS comes around, you have it already there.
Okay. Thank you.
Let me reframe some of what Stephanie is saying. Your CMS requirement is larger than maternity patients. So ours is no way sufficient. Our goal, though, is to try and get your maternity lined up to optimally meet CMS requirements, but also to provide the care that the moms need, which does go along with the next component of, and what percentage of women do you identify with social determinants who actually get services. So it's to help you better implement this within your maternity patients and not necessarily serve as all that's needed for CMS, because that's hospital-wide. Does that make sense?
Perfect. Thank you.
Wonderful. I believe we have covered all the questions. From here, what to expect from us. We will send you an email with the resources for the data collection, the instructions for data collection and submission. If your facility has already completed the data user agreement, we will send you the links to the data portal. And I will also send an email for you to register for the PQI webinar. That's about it. Ben, do you have anything else? Are we missing anything?
No, I think you covered it all. You'll be hearing from me and Estefania a lot in the coming months. We're excited for this initiative to start, and thank you all so much for joining.
Thank you, everyone. Have a wonderful day.
Thank you.